Today we are talking about non-invasive ventilation. So CPAP and BiPAP. This evolved after IPPB and more techniques were honed in and it became more comfortable to help ventilate our patients so we can do it without an artificial airway. So non-invasive ventilation supports the airway without an artificial airway. So this doesn't require an intubation or a tracheostomy. Non-invasive includes non-invasive positive pressure ventilation or BiPAP. And BiPAP is a commercial name that is used like the term Kleenex. We all call a tissue a Kleenex. A Kleenex is a brand named. BiPAP is a brand name as well. And then continuous positive pressure ventilation. Some early devices that were used are the pneumobelt, the rocking bed, and then the iron lung and the chest cuirass. So these early devices used gravity and application of abdominal pressure to help move the diaphragm to create the patient's breaths. Some of these are still used today, especially the pneumobelt. It's best for neuromuscular patients, so they can deliver about a tidal volume of 4 to 6 mLs per kilogram. So these are good for neuromuscular patients. And they deliver a tidal volume of 4 to 6 milliliters per kilogram. So this picture up here is a picture of a rocking bed. So right now you can see that it's facing up. The patient's head of the bed is up. So it will go all the way up. And because of gravity, it would pull the diaphragm down, which would expand the lungs. And then it would rock the other way, and the head of the bed would go down and the foot of the bed would go up. Not so much that the patient would fall off of the bed, but the foot of the bed would go up, and then that would force the diaphragm to go up with gravity and push the air out of the lungs. And during the polio epidemic, this is a picture of a ward with iron lungs for polio patients. And then the last pictures are pictures. This is the pneumobelt. So it wraps around the abdomen, and that hose has pressurized air in there. So it'll fill up the pneumobelt because there's a bladder inside the pneumobelt that fills up with air that causes that pressure from the outside to push on the abdomen. So when it pushes in, it's going to force the diaphragm up and the breath out. And then once that air is taken out of the bladder, it'll allow the diaphragm to drop and expand the lungs down. So the physiological goal, so know this, is to improve gas exchange by resting the respiratory muscles and increase alveolar ventilation without intubation. So this is the primary goal. We want to help a patient if they're breathing really hard, if they're in a COPD exacerbation, and they're working those muscles, those respiratory muscles very hard, then eventually they're going to poop out and their muscles are going to get tired and then they're not going to be able to breathe on their own. Then we're going to have to intubate them. So we want to intervene with non-invasive ventilation and let them rest those muscles without invasive ventilation. Non-invasive ventilation is used in both acute care settings and long-term settings. So you're going to want to know the difference between the two. So in the acute care setting, so in the hospital, we want to avoid intubation. We want to shorten the ICU because the longer the patient is in the ICU, the more that it costs. ICU stays are expensive, and we want our patients to get better. It shortens hospital stays overall, reduces mortality, preserves airway defenses. So when we intubate, we're bypassing the mucociliary escalator. So with non-invasive ventilation, we're not going to bypass that. It reduces the need of sedation most of the time, and it improves comfort. So we would want to try non-invasive ventilation before an ET tube because it passes the mucociliary escalator. The patient is going to not require that as much sedation, maybe some anti-anxiety medication. They have to be able to take off their mask, so they can't be too sedated when they're wearing this. What are some disadvantages of an endotracheal tube? So some disadvantages, we talked about bypassing the mucociliary escalator. They may be on the vent longer. It's more expensive for the ventilator. We are increasing the risk of infection, a viral or bacterial VAP. So VAP is a ventilator-acquired pneumonia. And why we are worried about those as respiratory therapists, not only do we want our patient to get them and get more sick, but once a patient develops a ventilator-acquired pneumonia, their insurance company will no longer reimburse the hospital for the rest of that stay because we caused the patient to be sick. The long-term setting refers to anywhere outside the hospital. So it can be a skilled nursing facility, it can be a long-term acute facility, or it can be at home. So some benefits here, it's going to alleviate symptoms of chronic hypoventilation. So this is a big one with neuromuscular patients. Some neuromuscular patients require this for sleeping because they already have weak diaphragms and small tidal volumes, so they need that extra help. Non-invasive ventilation also improves sleep. It can be given to patients with obstructive or central sleep apnea. Now, a formal sleep study needs to be done in order for them to qualify for one of these machines, but it'll improve their sleep, it'll decrease their risk of heart disease, and they will feel awake during the day rather than sleepy all the time. It also will improve sleep in those patients who have neuromuscular disease because they aren't going to have that buildup of CO2 and their tissues are going to get that oxygen that they need while they're sleeping. It'll improve the patient's FRC. So it will also improve survival because if you have a patient with sleep apnea, for example, and they've had it their whole adult life, maybe started in their teens, and their heart has been working harder every night to help deliver oxygen to the tissues, it's going to wear out. It's a muscle too, it's going to get tired. An example of this would be Reggie White from the Packers in the 90s, died in his sleep from a heart attack because he had sleep apnea and his heart just stopped. It just gave out. It's going to also help patients avoid hospitalization, and it's going to prolong survival. Here are some acute care indications. Know these, and we're going to go over them individually. In our COPD patients, so this is hypercapnic respiratory failure, which the definition is an inadequate alveolar ventilation with elevated arterial PaCO2 and decreased pH. So let's write that out. So the definition of that is inadequate alveolar ventilation elevated PaCO2 and a decreased pH. So it reduces the need for intubation. A patient with COPD, if they are intubated, they're very hard to get off the vent. They love to be on the vent. It gives their muscles a break and it helps produce that laminar flow into the alveoli to help avoid air trapping. So we actually had a patient and he kept asking us, he was on BiPAP and we did just his settings. And he's like, I've been intubated before, just intubate me, just intubate me. But we want to try and avoid that because then they're hard to get off the vent because you don't know if they're going to come off the vent. And that leads us into their length of stay and mortality. So it reduces the length of stay and mortality because they are so hard to get off the ventilator. And you don't know if they're going to be able to come off the ventilator. So COPD exacerbations, if we use non-invasive ventilation, it's going to decrease the muscle workload. And I don't know why it transfers like this. So decrease the muscle workload. It's going to decrease the respiratory rate and increase their tidal volume. So if they are in an exacerbation and they're using accessory muscles to breathe, they are just breath stacking. So they are trapping their air in their lungs. They're going to increase their PaCO2 that way. And we are going to offer assistance with the non-invasive ventilator. And that air and that pressure is going to help open the lungs and give them the time that they need to get that air all the way out. So take a second and think, what is the most common cause of COPD exacerbations? So lung infections are the most common cause. And the most common infections that puts them into exacerbation is influenza, rhinovirus, and adenovirus. So during cold and flu season, not only are you dealing with patients who have viruses who become sick, you're more likely to see more COPD exacerbations. So from these, remember your ABCs. This is how we're going to treat them. We're going to use antibiotics, bronchodilators, and corticosteroids. So how might your patient look who comes in with a COPD exacerbation that might require non-invasive ventilation? So these patients could be pursed lip breathing. They could have wide eyes, looked panicked, accessory muscle use, one to two word sentences. They're trying to breathe so much they may not even be able to talk to you. So you may be able to answer yes or no questions or ask, they may take a minute to answer the questions that you ask because they can't breathe. That's when you are going to ask the doctor, and he's probably going to already ask you, hey, let's get an ABG and see where they're at. It's helpful when they have family with them. If they have family with them, you can ask their family questions if they're having a hard time answering you, because we don't want to wear them out any more than they already are. Non-invasive ventilation is also good for asthma patients. It's good for patients who are in status asthmaticus that is complicated by CO2 retention. So the later phase of the exacerbation. We had a patient, and I think I was talking to pharmacology about this yesterday. We had a patient at St. Anthony's who was what we call a frequent flyer. So we all would look at his name and we knew exactly who he was and why he was there. But he would go up to Central City and gamble and sit at whatever game he was playing, poker, slot machine, whatever he was playing for that time, and he would feel an exacerbation coming on, start having those little symptoms, and then he'd just take his inhaler and take his inhaler and take his inhaler, but stay up there. He's also a smoker, so he was and a drinker, so he would be drinking and going outside to smoke and just sitting in the casino and gambling. To each their own. But he, as soon as he felt those signs and symptoms, he would take his rescue inhaler, but instead of when it progressively got worse, going to a facility and being checked out or going home and not smoking and not drinking and trying to get better, he would just stay there for days at a time. And he'd always end up in the emergency room via ambulance because things got out of control. So we would always try and start with non-invasive ventilation to try and prevent him from being on the vent. Because asthma, like COPD, that obstructive disease, it's really hard to get them off of the vent. It takes longer. So with non-invasive ventilation, their PaCO2 is going to decrease and their vital signs should improve within 2 hours. We can also put in line, so in the it is ventilator, in the ventilator circuit, in the BiPAP circuit, we can put nebulizer treatments. So they can still be on a continuous neb or a small volume neb to help reduce that bronchospasm while they're getting steroids. So during non-invasive ventilation, they're going to get bronchodilators, so beta 2s, and they're also going to get corticosteroids. Oops. And that's going to be via IV. So like Solu-Medrol is a common one you may hear in the ED. It works fast and it's right to the point. So using non-invasive ventilation with asthma patients are going to decrease intubation, complications, and mortality rates. If we have a patient with hypoxemic respiratory failure, so they're in respiratory failure because their PaO2 is so low that the body needs help getting oxygen to those tissues. It can be used for supportive care before intubation. So before we intubate that patient, we always pre-oxygenate. So we can use an ambu bag, we can use non-invasive ventilation, or we can use a non-rebreather. Using this is going to improve gas exchange, it's going to decrease the ICU stay, and oxygenation will improve within an hour. So this here is saying, okay, so they have hypoxemic respiratory failure. So they're not necessarily going to go straight to CPAP, BiPAP. We could also do heated high flow. So heated high flow, and that's a nasal cannula. So heated high flow is something very cool. It can prevent the need for intubation for oxygen needs. Because we are not currently on campus, I recommend going to Vapotherm, and I can post the link because they also have CEUs for RTs, So once you're out in the field, every 5 years, you have to have so many CEUs that you have to turn into the MBRC to keep your credentials. And they have a bunch. But while you're in school, you can use those for professional hours. So I will post the link for that. Moving on. So it decreases the need for intubation, which also decreases the mortality rate. If they're not on heated high flow or they're not already on BiPAP for another reason, and you only have a BiPAP machine available and you don't have any heated high flows, you can always start the patient on CPAP on a CPAP of 5. So CPAP of 5. And we'll get more into settings as we go into the lecture. Acute cardiogenic pulmonary edema. So this is also known as CHF. So if you see CHF, this is what it's referring to. So it's pulmonary edema that's caused by the heart. So it's the left side of the heart. Left side of the heart. So that left side of the heart doesn't work like it should. It's bigger, the ventricle's stretched out on that side, and it doesn't squeeze as hard. So it's not getting all of that stroke volume that it usually does. So things start to back up. Now, if they are having an acute exacerbation of their CHF and the heart's not pumping like it should, the lungs are going to develop pulmonary edema. So if we have lots of fluid in the lungs, they are going to decrease their oxygen into the tissues and increase their PaCO2 because they're not having the adequate gas exchange. With CHF, we are going to notice first that their oxygen is lower. They're not necessarily chronic CO2 retainers like COPDers. They have more of an issue with oxygenation. So we are going to get the ABG for CHF because it's an oxygenation issue. If we add pressure, we are going to start. So this is important to know that we start with a CPAP of 8 to 12 centimeters of water pressure. Always watch your units. So we're going to start with that pressure, and that pressure is going to help flow in and push the fluid out of the lungs back to where it needs to go. So that extra pressure is pushing the fluid in the lungs back to where it needs to go. If that's not working and they become hypercapnic, then you will add BiPAP. So that pressure is going to expand the alveoli and open them, and it's going to push that fluid back. And that is going to result in an increase in oxygenation, a decrease in work of breathing because they're not having to overcome that fluid in their lungs to try and get those oxygen to the tissues. It'll decrease the ICU stay. Because it's expanding those alveoli, it's going to increase their FRC. And we're decreasing intubation and mortality rates, and we're increasing lung compliance. So try and take a minute and think about what these patients might look like. Okay, so they may have accessory muscle use as well because they're trying harder to breathe. They maybe have wide eyes. Oops. When it comes to breath sounds, they have a lot of fluid in their lungs, so they're going to sound coarse or rails. It's funny how RTs come up with different names. When I first started, after I was a new grad, What I loved about my hospital is I was able to start in the ICU because they're mainly an ICU hospital. And I was orienting with one of my friends. She became one of my friends. And she was like, "Oh my gosh, this lady sounds like a washing machine." And I was like, "What the heck is she talking about?" And so I listened to her and I was like, "She just sounds really coarse." And I was like, "But not coarse from mucus, coarse, coarse from fluid, coarse." And I had an aha moment and I went and looked at her chart and she had CHF and she was having an acute exacerbation. So it's hard to explain to you guys what lung sounds sound like until you hear them. So don't get frustrated with yourself if you don't understand what something means. And you're going to have these great aha moments, I promise you. So if you hear someone say they sound like a washing machine or they sound wet, what they're referring to is pulmonary edema, because coarse breath sounds there's so many different reasons for those. So coarse breath sounds like rhonchi because of mucus is going to sound different than coarse breath sounds because of fluid. So I'm missing a whole slide from my PowerPoint. I don't know where it went. So we're going to do this. So you can pause and I'll write everything that I'm saying so that you can write it as well in your notes. So non-invasive ventilation is also used with immunosuppressed patients. So these patients may be patients that are immunosuppressed, whether they're on neutropenic precautions. So side note, anytime you're wondering about precautions, we had that exercise about C. diff. The CDC, so cdc.org, or you can just Google um, the precautions and go to the CDC's website, and it will tell you, because that's where hospitals are getting their standards from, is the CDC. So whether they're on contact precautions or isolation precautions or anything about that specific pathogen that needs to be taken care of in a different way, the CDC will mandate standards for that. So neutropenic precautions. So that would be someone who is on receiving radiation and chemo. And neutropenic precautions means they don't have the ability to fight off infection. So if you have a runny nose or a cold, you should not be seeing patients on neutropenic precautions. They cannot have things like flowers or plants in their room from visitors. It's a precaution not for us because we don't want to spread a pathogen. It's a precaution for them. So it's called a reverse precaution. So we are taking precautions so that we're extra careful and we don't bring anything into their room. Okay, so immunosuppressed patients and then patients who are waiting solid organ transplant can develop hypoxemic respiratory failure. So by placing immunosuppressed patients on non-invasive ventilation, we are going to decrease intubations. And this is a good thing because due to significant risk of VAP, so we went over ventilator-acquired pneumonia, in this patient population, non-invasive is considered first-line therapy. So because of VAP, non-invasive is first-line therapy. So infection in these patients can have a devastating consequence. So if you have a patient who's immunosuppressed and they can't fight off a pathogen that most people can fight off, it will increase mortality. We also want to protect those who are awaiting organ transplant because if they become sick, they may be taken off the transplant list. So it's important that we create less chances of having a VAP and we use non-invasive ventilation when possible. Okay, so palliative care. Palliative care, you are going to go over in pediatrics as well, and you will talk about the difference between palliative care and hospice. So, palliative care, we are having someone be more comfortable, it's towards the end of their life. And then DNI stands for do not intubate. So, these typically are older patients who may have a DNI. They may also have a DNR, which is do not resuscitate. That's something that you should always look in your chart, and you should be giving and report, especially if you're in the ICU. So we use it only if it makes patient more comfortable or to manage a reversible disorder. We don't want to put somebody on this, although it's non-invasive, we don't want to put anyone on this ventilator that's going to extend their life when they wouldn't want that. So only if it reverses a manageable disorder. I remember going to the ER with my charge one time. She needed help getting an ABG, and it was this sweet little old man, and you could just tell he'd been working hard all night. And she was talking to us about him, and I had done a couple ABGs on him. He was 92 years old, and he needed a BiPAP, but he was a DNR DNI, and he didn't want to wear it. He was adamant, he was in sound mind, he didn't want to wear it. But then as the night progressed, his CO2 started to build up, and so he became lethargic and wasn't quite with it. And so, but his family wanted him to wear this non-invasive ventilator and wear the BiPAP. So the physician put on the mask and had us, it was right before shift change, had us take him to the ICU. He was a DNR DNI. So family can overstep that boundary. There are a couple states that say that family can't reverse those orders. Colorado is not one of those states. So even though you know that the patient should not be on ventilation, you still have to do as the doctor orders. Um, and it's not our place to tell the family what they should do. If they ask you advice, be very cautious on how you say something because it can always be taken and misconstrued the wrong way. So he ended up passing away. The family talked to the critical care doc who explained to them what was going on and that the only thing keeping him alive was this BiPAP. And so they eventually withdrew care on him and let him pass peacefully. So there are going to be situations where you do that. Sometimes non-invasive ventilation can be used. So if you have family members who are out of town and they want to come say goodbye to their grandma, their grandpa, their mom, their dad, they just have to get into town, but we don't want to intubate them, we can use non-invasive ventilation. So more on DNI. So DNI orders with COPD exacerbation or cardiogenic pulmonary edema. Non-invasive can help if the acute condition is reversible. So if you have a COPDer and they've been intubated before and they're like, oh, heck no, I'm not doing that again. That was terrible. I've lived my life. I don't ever want to be intubated again. If they are having an acute exacerbation and we can catch it in time and get them on BiPAP and have them blow off that excess CO2 and rest those muscles, it's okay because it's an acute condition that is manageable and we can reverse it. So palliative equals comfort from symptoms. So we will use on palliative so we can give them comfort from symptoms. If the patient is end of life and non-invasive is not comfortable for the patient, discontinue. So if they're not receiving relief from non-invasive ventilation, you need to DC it. So for our post-op patients, it's primarily showing potential with obese patients who have undergone major abdominal surgery. So it's used for obese. Because remember, obese patients, it acts like a restrictive disease. So if they have abdominal surgery or thoracic surgery, it's going to be extra painful because they have all that weight on the surgery site. And there is insufficient evidence to warrant use of BiPAP all the time. So an example would be at our hospital, we would always, so post-op was across, the ORs were across from the ICUs. So there's respiratory closets, and this is with any hospital, there's going to be respiratory closets with your equipment in major areas. Like in the ICU, you're going to have a respiratory closet that has ventilators, heated high flows, BiPAPs, intubation supplies, all the stuff that you need tailored for that specific unit. So in post-op, we would always keep one ventilator and we would always keep one BiPAP, because those post-op nurses will call you and be like, hey, will you come assess this patient? They're just coming out of surgery and out of anesthesia, so they may still be taking those smaller breaths. They may have retained secretion, so they just need that extra help to wake up until the medication is out of their system. So post-extubation, we can take extubated patients and put them on non-invasive ventilation. This is going to help prevent reintubation. So hospitals have to have a certain amount of percentage of failed extubations where they get reintubated, because that shows that we're trying to get them off the ventilator. We're aggressively trying to wean them off the ventilator and get them extubated. Some doctors may say, hey, I want to try and extubate Mrs. Smith today. She's done okay on her weans. She just works a little hard. Let's try and put her on BiPAP and see if we can get her over that hump. But if they are not improving within an hour or two, you're going to reintubate. But putting them on non-invasive ventilation and making sure they're oxygenated and they're resting their muscles, it's going to create a safer environment for reintubation rather than putting them on a nasal cannula and then all of a sudden their muscles poop out and we have to have an emergent intubation. We would rather have that controlled, okay, we see where this is going, let's get this stuff together and let's intubate, rather than the, oh no, she's totally apneic, or her sats are super low, we got to get this tube in there and we got to get it in there now. And then the patient's less likely to need a trach. So if we can get them past that 1 or 2 hours, they're less likely to be reintubated and needing a trach. So a couple long-term indications would be nocturnal hypoventilation. So that's our OSA, CSA, and any sleep disorders. It's also indicated for restrictive thoracic diseases. We want to help increase their tidal volume. So neuromuscular patients, obese patients, and other long-term indications may be COPDers, because now they have non-invasive ventilators and they can do a thing called sipping. So if they feel really short of breath and they feel like they can't get a big enough tidal volume, they can take a mouthpiece that's attached to a BiPAP and trigger it similar to an IPPB. So there's a change in flow and pressure. So they trigger it to give them a breath to help expand their lungs, so that if they feel short of breath, even they may just take a couple big breaths off of that and they feel better because it opens their lungs. It allows that air that's been trapped to have that laminar flow and come up and out. Some long-term disease processes would be central sleep apnea, obstructive sleep apnea. You also can have both, which is mixed sleep apnea. And remember, these require a sleep study to diagnose. So patients who are in the hospital for other reasons and they wear a CPAP at home, you're going to find that out during the respiratory assessment, and the doctor will order that so that they can also have a a CPAP at the hospital. It's important to make sure that you're screening patients so that you can give the same treatments at the hospital that they would do at home if they were not sick. So what the non-invasive ventilator is going to do for these patients is it's going to prevent that chronic hypercapnia that's associated because of the hypoxemia. So it's going to augment their tidal volumes. And so when they go into an apneic period, the machine is going to deliver a continuous pressure that's going to keep those alveoli open so that there is still gas exchange. It's going to help rest the muscles, including the heart. So the heart's not going to have to work as hard to get what oxygen is going into the body to the tissues because there's going to be more constant pressure to deliver that oxygen. And it's going to lower CO2 because it's going to augment that gas exchange. So you're also going to have improved compliance, FRC, and reduced dead space. So restrictive thoracic diseases that may require non-invasive ventilation would be post-polio syndrome, neuromuscular diseases, any chest wall deformities, spinal cord injuries, severe kyphoscoliosis. So initiated with symptoms of nocturnal hypoventilation. So these are diseases that are more likely to require non-invasive ventilation at night. So even in the hospital, if you have a patient who comes in and they have a neuromuscular disease, most of the time they are going to require a BiPAP at night. Some hospitals will let patients bring their machines from home, and some will require that they use the facility's machines. So with ALS, ALS, also known as Lou Gehrig's disease, is amyotrophic lateral scoliosis. So that's progressive muscle weakness. So as the disease progresses, all of their muscles throughout their body is going to start becoming more weak, and that includes the diaphragm. So these are important to know. Know when to select these. So if your patient is using accessory muscles, you wouldn't necessarily go for if you can just see a little bit of work of breathing. You're going to see their shoulders rising. You're going to see them using their intercostals. They're going to be pursed lip breathing. You may see them in the tripod position if they're paradoxical breathing. If their respiratory rate is greater than 25, and you're going to also want to know when this started. If they have moderate to severe dyspnea. So if they can't answer your questions or even talk, you may want to start them right away on BiPAP. If their PaCO2, and that should be greater, is greater than 45 with a pH less than 7.35. So if they're becoming acidotic and you can see it heading towards intubation, try non-invasive first. And then if their P to F ratio is less than 200. So these are a lot of standards that you're going to look at, but you're also looking at the patient. You're looking at what is causing this. Can I reverse it with some medication? Are they too far gone to respond to, say, a bronchodilator if you have a COPD exacerbation? So you're looking at the patient, their history, and what's going on with them currently. It's easy to look at the piece of paper and say, oh, well, their respiratory rate is 26 and their PaCO2 is 47. And then you look at their history and they are in for a trauma. Well, they're in pain. Maybe let's try giving some pain medication. They're hyperventilating. Let's try that first before non-invasive ventilation. Now you can look at the piece of paper and say, okay, they're at 27 and their PaCO2 is 56 and their pH is 7.3 and they're a COPDer and this is their second trip here in 5 months. And last time they had to be intubated. So that would be someone that you would be like, oh, well, let me grab the BiPAP. So it's going to be a combination of things. Okay, so for exclusions of non-invasive ventilation, apnea. If a patient is apneic, they cannot be on non-invasive ventilation. So if a patient is apneic, they cannot be on non-invasive ventilation because in order for this to work, they have to be able to trigger breaths. We can set a respiratory rate and we'll go over settings, but it is more like a backup rate. If they cannot protect their own airway, we will just intubate. If they're hemodynamically unstable, we want to make sure that they have a patent airway. If they code, if they're, say they have hypotension and we're afraid they're going to code, we want them already intubated so that we don't have to worry about intubating while we are coding them. The patient has to cooperate. You guys are going to have some great stories as your career goes on from patients and BiPAPs. Some patients are like, oh, thank goodness. And then you're going to have patients who freak out every time you try to put them on it and refuse to wear it. You'll have patients who, as soon as you get it right where it needs to be, they say, all right, now I need a drink of water. So that happens. Your patient has to cooperate with them. And then you'll have nurses say, well, can't we just restrain them and put the mask on them? They have to be able to remove the mask. If they feel like they're going to throw up, they have to be able to take that mask off because we're worried about aspiration. If they have facial burns or trauma, we're not going to be able to get an adequate seal and we can cause more damage than good to the patient. If they have copious secretions and they cannot maintain them, then we need to think of another option. So there are many different options for face masks. In the hospital, you're primarily going to see a nasal mask and a full face mask. Those are the two typical ones you'll see in the hospital. The mouthpiece I was talking about for COPD, and that's when they sip and they can take that breath on their own. You also have a total face mask, nasal pillows, and a helmet. So a total face mask, and we have pictures, so we'll go over all of these. A total face mask, some hospitals do carry. Nasal pillows are typically only used for home CPAPs, and they're more expensive, so the hospital doesn't carry them. So it is important to have the proper fit, because if you have a leak, it's going to cause the patient not to get the correct tidal volumes. Depending on what mode of ventilation you're using, it can mess up the pressure. Okay, so we'll start at the top. So this guy here, that's a total face mask. So it's typical for claustrophobic patients, which you think is funny because this doesn't cover as much, and this is the full face mask. So total and full. So we like to call the total face mask the Jason mask. And then here you have nasal pillows. And then this is just a nasal mask. So modes that we will go over are CPAP and BiPAP. And there's also available is AVAPs. Make sure you watch that video because it's not on your boards, and it won't be on your test, but when you're out practicing, it's good to know what AVAPs is because it's used quite often. So for us, we're going to do CPAP, which is continuous positive airway pressure. Continuous positive airway pressure. And then you have BiPAP, and it's biphasic positive airway pressure. So it's two different pressures. So you have spontaneous and timed, and these are breaths. Spontaneous and timed breaths. So the patient is able to trigger a breath once there's that change in flow on spontaneous, but then we are going to set a backup rate. So if we set a backup rate of 10, the machine automatically every 6 seconds will give a breath. It will start a breath. Okay, so IPAP is the ventilating pressure. So IPAP stands for inspiratory positive airway pressure, and that is what we're going to use for ventilation. Okay, and then we also set EPAP, which is expiratory positive airway pressure. Oops. Sorry about my handwriting. And that is for oxygen. So something else about EPAP. So we have CPAP equals EPAP. So they're both baseline, which equals PEEP on mechanical ventilation. So those are all our baseline pressures. And they control oxygen. So if you have an oxygenation issue, you're going to adjust either the CPAP, the EPAP, or the PEEP. If you have a CO2 issue, you're going to adjust IPAP. So these are pictures of breaths. So if we have a patient and let's say they're on CPAP, we do not set a respiratory rate for CPAP. So here you can see this would be a patient's breath. So this is a CPAP of 5. So that will always be at a pressure of 5. And when I talk about a pressure, we don't have pressure in our lungs. So we at baseline or at 0 with normal breathing. So if we set a pressure of 5, we are setting that pressure and it is going to be continuous with CPAP. So the machine the whole time will always be delivering a pressure of 5 to the patient, and that's going to pop open those alveoli. And here you can see the patient's breath. So here they're at baseline, and they're breathing out and in, and out and in, and out and in. So they're choosing their tidal volume, We're just giving them that extra help to keep the alveoli open. So here we're moving to BiPAP. So we have set an EPAP and we have set an IPAP. So this is going to be expiratory pressure. So baseline. So we remember TLC, bro. This is our baseline. The IPAP, now there's no limit here. The IPAP is at 10. So it's going to, on expiration, at baseline, it's going to be a pressure of 5. Here on inspiration, as soon as the machine feels that the trigger that the patient is triggering a breath or the machine is timed and it's delivering its own breath, it's going to increase that pressure to 10, which is going to increase tidal volume. So it's going to increase the tidal volume. So 5, the patient triggers a breath here. You can see it triggered. So as the patient breathes in, this whole time they're getting an IPAP of 10. And the patient gets to decide how long they want to take a breath. And then when they're done, they exhale on their own. So they'll put it into expiration. They exhale, they go back to baseline at 5. Now in C, the IPAP has been increased to 15. So you can see the patient triggers it here. So the machine's delivering the breath with a pressure of 15. So it's going to increase the pressure, which increases the tidal volume, which increases the time above baseline. So you can see compared to B, this breath is a lot bigger. So this patient, this is where we start, 5/10. So the patient started at 5/10. That just wasn't big enough. Their respiratory rate was the same. Maybe they just need bigger breaths. So we changed the IPAP. Well, that wasn't working. So the EPAP was changed to 10. So now baseline is 10. So the whole time on exhalation in between breaths, the patient is going to be at 10 and the IPAP is at 15. So see, even if the IPAP is increased, or excuse me, the EPAP is increased and the IPAP remains at 15, it's a smaller breath than C. So what we see here is pressure support. So IPAP minus EPAP equals pressure support. And our pressure support is what controls tidal volume. That's what controls tidal volume. So the more time above baseline, the bigger the breath. When we are using BiPAP, especially BiPAP, anytime we have pressure, we need to add humidification. So we need heated humidifiers. Why? Because the pressures are going and the breaths are going in so fast that we are bypassing that upper airway, not totally, so it still humidifies it a little bit and heats the air a little bit, but it's not doing the full job. So we need to add humidity to aid the patient in humidifying that air, and we are going to heat to about 30 degrees Celsius. When we start non-invasive ventilation, we want to place the patient's head of the bed at 30 degrees or higher, because if they're laying flat or they're laying down, they're not able to get those big deep breaths. All the blood is going to, from gravity in the lungs, is going to settle at the bottom. So we want them to sit up higher. We don't want gravity to push down on the chest. And if they're obese, that's going to add more restriction to their lungs. So 30 degrees or higher. We want to make sure that we have the properly fitting mask or interface so that they can there aren't any leaks so that they're comfortable. We want to make sure it's not too tight, but we don't want it to be too loose as well. We want to select the appropriate mode and settings. So we want to make sure that we're starting on BiPAP if it requires BiPAP or CPAP if it requires CPAP. So remember, for CHF, we're going to start on a CPAP of 8 to 12. And then we'll check for air leaks and make sure. There will probably be some, but we should make sure that it's not too much where the BiPAP is going to alarm, where they're going to lose volumes, or they're not getting the pressure. So settings, so PEEP, EPAP, or CPAP should be 4 centimeters of water pressure or greater. We're going to set our inspiratory pressure based on tidal volume. So this should be 5 to 8 mLs per kg. Because that's what we're doing is the ARDS protocol. We want to make sure that they have adequate lung volumes, that it's not going to cause damage. So this is when we would do the ideal body weight equation. So remember, for males, we are going to do 106 plus 6 times height in inches minus 60. And then for females, we're going to do 105 plus 5, and then times height in inches minus 60. And then, so once you get the answer, and we need, remember, this needs to be kilograms, so we need to convert to kilograms. So let's say we have a female and her ideal body weight is 60 kilograms. Then in order to get the range that we need to multiply it by 5. So we're going to say 300 there. So her range will be 300. And then we're going to multiply 60 again by 8. So that would be 480. So her tidal volume range is going to be 480. So what we're going to do is we're going to set the inspiratory pressure so that we are aiding her in taking a range of 300 to 480. So if your patient is tachypnic and they're working hard to breathe, they may be taking huge, giant breaths at first. That's okay. What we're doing is we want them to let the machine help their accessory muscles and help their diaphragm breathe. We want to rest it so she can calm down and she feels her body doesn't feel like it needs to take those huge breaths in order to get the oxygen to the tissues. Now, your pressure support should always be a minimum of 4. So if you have an IPAP of 8, the minimum that your EPAP should be is 4. So if you adjust the IPAP and say you adjust it from 8 to 10, then you're going to adjust the EPAP so that your pressure support is still 4. Now, if you want to increase tidal volume, you don't have to adjust the EPAP. You want to leave the EPAP the same. So if you can increase one without the other. Now, if you don't want your tidal volume to be the same, or your oxygenation needs a boost as well, you can increase both. So we are going to see, this is how we gauge if we're being successful or if we're being a failure. So if we're being successful and the non-invasive ventilation is working, we're going to see improved ABGs, a decrease in work of breathing, and overall clinical improvement. So she's able to speak again. She can take breaks off of the non-invasive ventilator and take a drink of water. Those little things, you're going to look at the patient. Now, we know that it's not working if there are absolutely no changes in 1 to 2 hours. And if we wait too long and we're just like, well, let's see what happens next, it can lead to cardiac arrest because their heart is working so hard to try and improve gas exchange that it's going to wear out. If they go into hypoxemic respiratory failure and their heart's not getting the oxygen that it needs, it's going to lead to cardiac arrest. So we will go over these one by one. So ABGs. So if your patient has a high PaCO2, we can increase that pressure. And the pressure that we increase, we can increase IPAP, because IPAP equals ventilation, or we can increase pressure support. Which if you increase IPAP, you're going to increase pressure support as long as you leave the EPAP alone. If you have a low PaCO2, you want to do the opposite. You want to decrease pressure, so IPAP, or the rate. Now, if they're triggering their own breaths and they're over breathing your rate, decrease that rate. That's going to be more imperative on mechanical ventilation. We want to adjust the pressure because adjusting the rate may not work on non-invasive ventilation because that rate is often for backup. So if we have a high PaO2, we want to decrease oxygen, CPAP or EPAP, because remember, CPAP equals EPAP, which equals PEEP. And if we have a low, we're going to write this over here. If we have a low PaO2, we'll do the opposite. We will increase oxygen, so FiO2 or CPAP or EPAP. Okay, so let's talk about setting up a patient. So let's say you have an IPAP and it's at 8. So the minimum pressure support you need is 4, which would be an IPAP of 4. So we're going to draw this volume here. So we'll say that this is their breath. So we have an EPAP. So this is EPAP down here, and it's at 4. This is our IPAP up here, and it's at 8. So this is their tidal volume. Now let's say that you get an ABG, and that IPAP, the CO2 is still acidotic. So you leave the EPAP the same, but you increase the IPAP to 10. So the EPAP is still at a baseline of 4, and the IPAP is now at 10. So your pressure support here is 4. Your pressure support here is 6. So you've increased pressure support and you've increased IPAP. So this is your tidal volume. So it's bigger. They're going to spend more time above baseline. So let's say you wait a few hours and you get another ABG. So you get the ABG and now their oxygenation isn't as good. So they're resting, their CO2 is fine. So you want to increase oxygenation. So increase oxygen. You can increase FiO2, but then for this scenario, we'll just say that their FiO2 is already at 100%. So they have an EPAP of 4, so you can increase it. So let's increase it to 6. So you increase it. So we're going to start here. So this is 6, and this is still 10. So now we have an EPAP of 6 and an IPAP of 10. So their pressure support is back to 4. So the breath is a little bit smaller. And let's say their CO2 starts to rise again. So you want to leave, but their oxygenation looks great. So they're still on an EPAP of 6. And maybe we just need to go up to 12. So we're going to increase that IPAP to 12. So now they have a pressure support of 6 again. So you don't have to increase both of them, but it would have been smart on this breath here. Their oxygenation might not be fine, but we found that a pressure support of 6 helped their CO2, helped them blow it off more. So that is, at that time, we should have increased the IPAP to 12. So let's do a little scenario. So let's say we have a COPD and this is their ABG. Okay, so we have a respiratory acidosis. So we want to start them on BiPAP because we want to help blow off that that CO2. So let's start IPAP and EPAP settings. Let's say their respiratory rate is 28. So you have an IPAP, let's say we want to start it at 10 and 5. And then we'll set the backup rate to 12. Because if they're not triggering a breath, then the ventilator, the BiPAP machine, will automatically give them a breath. But as long as they're triggering it, they won't necessarily get that breath because the machine doesn't have to time one for them. So that's essentially a backup rate when the BiPAP is on. So you start them at an IPAP of 10 and EPAP of 5, and we'll look at the oxygens at 70. But they are COPD, so we don't want to start the FiO2 too high. So we are going to set the FiO2 at 40%. So you wait a little bit, and when you start non-invasive ventilation with a patient, you want to wait to do an ABG for at least 30 minutes because you're not going to see changes for at least 30 minutes. So let's say the doctor says he wants a repeat ABG after an hour. So it's been an hour and you get the following gas. So post non-invasive 1 hour. And we're going to say that it's 0.733. So there's a little bit of improvement. The doctor's not quite satisfied. So he wants you to adjust the ventilator appropriately. Well, we can see that it's a respiratory issue and it's acidosis. So because it's a ventilation issue, we are going to adjust the IPAP. So the IPAP is currently at 10. So we're just going to increase it to 12. Now, 76, there was improvement. And so in Colorado, we wouldn't do it. We wouldn't change anything because he's a COPDer. He's at altitude, so that's a good PaO2. Now, at the Unicorn Hospital, you could adjust the EPAP. But remember, you want to fix the respiratory acidosis first. So you adjust the IPAP and then the EPAP. So we are going to put it at 7. Now that pressure support is still good because we're still at a pressure support of 5. So pressure support of 5 here, pressure support of 5 here. And the rate will still stay the same, and we'll leave the FiO2 at 40 because EPAP equals oxygen and we increased it. So let's see what happens here. So we'll say we wait another hour. The patient's transferred up to the ICU, so the ICU therapist gets a blood gas and it looks like this. So now he's 7.34, so he's almost to normal. He's at 47, 80%, or PaO2 of 80, and bicarb is normal. So we did it. We fixed him. He probably lives somewhere close to here if he's a COPDer because he's a chronic retainer. And even though this pH isn't in normal range, he's getting close. So you want to just trend it. I would leave your settings the way that they are and then get a repeat gas in a little bit. He's up at 80, so he's doing good on PaO2. All right, so now we are going to go over what we call the 60-60 rule. And this is something you'll keep getting in the program. We go over it again in emergency care. You'll go over it in IMV. I'm sure Derek has explained it to you. So once the patient is stable, so once they're on non-invasive ventilation and they're stable, we want the FiO2 less than 60 while maintaining a PaO2 of 60 millimeters of mercury. So we have a stable patient. So what we want is FiO2 less than 60. While maintaining a PaO2 of 60 millimeters of mercury. So we're going to draw a flow chart. So we have a PaO2. We're going to look at PaO2. So remember 60-60. So we are going to adjust FiO2 until at 60%. So once we hit that 60%, then we want to increase mean airway pressure, or we want to increase time above baseline. And that will be an increase in mean airway pressure, or MAP. So that's also known as the king of oxygen. And we can do that by adjusting our EPAP, CPAP, or PEEP. We can also do that by playing with their tidal volume, so pressure support. So if we increase pressure support, we're going to increase the time above baseline. When we monitor a patient, we want to make sure that we're assessing for leaks. We're assessing for accessory muscle use. Are they still working hard to breathe? Are they comfortable? We're watching the patient. If they're still struggling and they're using a lot of accessory muscle use, you want to increase support. You want to increase the help that we're giving them. So it may mean increasing pressures. So for patient comfort, you are going to adjust rise time. And the rise time is how fast the patient gets the breath. And then we're going to look at improvement. So we're going to look, have their saturations improved? Have their ABGs improved? Do they look like they're still working hard to breathe? So complications of non-invasive ventilation include mask-related problems. So when you are looking and assessing your patient, when you're checking on them, you want to make sure that there's no breakdown of their skin, especially the bridge of their nose. That's the thinnest skin on your body, is that bridge of your nose, so it breaks down fast. If you may have patients who use Mepilex. The nurses put Mepilex, which is a barrier, and it's used for wound care to help soften and take away pain from their breakdown of their skin. That's going to cause more leaks, and the patients aren't going to get as adequate breaths. So that's when you need to look at if your hospital has total face masks, putting on a total face mask or trying a different mask to help them with that breakdown of their skin. You may have flow-related problems. So the machine isn't adequately giving the pressure that it needs. You could have air leaks. So the mask, again, that's the biggest complication and number one problem that goes wrong when using non-invasive ventilation is those air leaks. You can put a T-piece that a small volume neb can go into on a circuit for a non-invasive ventilator, and if the cap isn't on correctly or the corrugated tubing, the ventilator circuit itself, isn't put on there all the way, it can cause a leak. Back to flow related problems, now that we talk about small volume nebs. When you tee in, is what it's called, if you tee in a nebulizer and you turn on the flow meter, that extra liter flow is going to make it look like the patient is getting more volumes, and it's going to increase the flow to the patient. So the machine may alarm. So just be aware of that. Patient comfort. So you're going to have those patients who just don't want to wear it. Don't be offended if someone starts yelling at you about it and hims and haws. It happens. Just know that it's going to happen. And then you have these nice, cute little old ladies who are so sweet and they have no problem for the day shift. And then you come on night shift and you tell them that it's time to wear their BiPAP, and they just turn into a totally different person. It happens. Be aware. Complications, maybe it may not work. This may be something that they need to be intubated and non-invasive ventilation works because there's no improvement of gas exchange. So know your serious complications. They're not as common. Aspiration. We need to make sure that the patient is alert and awake and able to take off that mask if they become sick. Hypotension. That's that squishy squish that we talked about with IPPB. So we're adding this pressure to their lungs. It can squish their heart if you have high pressures. It would have to be very high pressures, but it's possible. Or if they have cor pulmonale or CHF, and that's why we start CHF in CPAP, because we don't want to add too much pressure to their heart's already weak as it is, and the left side, that ventricle is floppy and bigger and it doesn't squeeze as hard. So it's a possibility that it may cause hypotension. And then the bottom one, I don't know why you can't see it, is a pneumothorax. Anytime we add pressure to the lungs, we risk causing barotrauma. It can happen, especially with those emphysema patients and those COPDers who have blebs on their lungs. It's more likely to happen. So know your signs and symptoms, especially for aspiration and pneumothorax. So if you have a patient and you're watching their BiPAP and you can't see, you see they're not getting their tidal volumes, they look like they're struggling, and you listen to their lungs and you hear one side is diminished or absent, then you know that you need to get a chest x-ray stat and see if it's pneumothorax.